Have you ever wondered what is the origin of that 5-digit code that you see when your doctor orders a lab test on you or an imaging test? Or like after you see your doctor, they hand you a piece of paper and you take it up to check out what those numbers are, where they came from, and what they mean?
Welcome to the Doctor's Mentor Show. If you believe that medicine is an industry and not a profession, if you enjoy submitting complex reimbursement claims, or you would do another residency just for fun, be advised, you're about to be offended. You should probably leave now.
All this talk about mentoring doctors is ridiculous. I thought doctors learned to do everything better than everyone else the first year of medical school. At least that's the way they act.
If you love assisting patients with vitality breakthroughs, if the right to practice medicine without interference is important, and you want expert tips for practice freedom and profits to support your epic life, welcome aboard and prepare to be blown away. The Doctor's Mentor Show starts now. Here's your host, Dr. Lori Barr.
Have you ever wondered what is the origin of that 5-digit code that you see when your doctor orders a lab test on you or an imaging test? Or like after you see your doctor, they hand you a piece of paper and you take it up to check out what those numbers are, where they came from, and what they mean? We're going to delve into that today. So we're going to answer those questions. This is a primer on relative value units and CPT codes today. So thank you for joining us. So first, let's talk about the relative value unit and what used to happen before. RVUs came about. RVU stands for relative value unit, and they came about in the 1980s. But before that, when you would go see a doctor, it was kind of like going to see a hairdresser or a barber. In one town, you go to get a haircut and it costs one value. And if you go across the country and get a haircut, it might cost more, it might cost less. Well, that's how medicine was. It was fee for service, and there was a lot of variability across the country for the very same services, and sometimes even within the same town for the very same services. So in an effort to make all of that more transparent and more fair, a Dr. William Hsiao in the 1980s, who is a Harvard economist, came up with the concept of the relative value unit, the RVU. Now, the relative value unit is a standardized measure used in the United States that determines the value of physician services for reimbursement purposes. So rather than assigning a specific dollar amount, the RVUs quantify the relative worth of a medical service or procedure compared to others, and it's based on the resources required to provide it. The system is foundational in how Medicare and many private insurers calculate physician payments, so it's nice to have a baseline understanding of what this is and what it's used for. The RVU is also related to the CPT code, and the CPT code, we're going to talk about both of these, is the current procedural terminology code, which is a standardized 5-digit code used by healthcare professionals to describe and document medical, surgical, and diagnostic services and procedures, and it's developed and maintained by the AMA. So CPT codes provide a common language that streamlines reporting, billing, and administrative processes across the healthcare system. Think of it like the euro. Before, there were different currencies all throughout Europe, and then the euro came along and made it a lot easier to cross borders and spend money. Same thing with the CPT codes and the RVU system. It's a way to have a common denominator to communicate about how resources are allocated and how much it costs to do the business of medicine. So like I said, Dr. Hsiao, the Harvard economist, came up with this system in the 1980s along with his team. And the whole idea was to make it more transparent what was happening so that, it'd be more fair for patients across the country. And after that, what happened is in 1989, the Omnibus Budget Reconciliation Act gave rise to the resource-based relative value scale. And that's the RBRVS, which embedded RVUs into the Medicare payment system. And this act, the whole purpose was to control rising healthcare costs and bring consistency to physician payments. In 1992, then, Medicare formally adopted the RBRVS, that resource-based relative value scale, that linked physician payments to RVUs rather than billed charges. And this was a transformative shift in how healthcare services were valued and reimbursed in the United States. That changed medicine and the way we practice it considerably. So CMS, the Centers for Medicare and Medicaid Services, oversee the Medicare program, and CMS is the final authority on annual updates to the physician fee schedule, which incorporates RVU values. Now, the RVU has three components. The first component is the physician work RVU, which reflects the time, technical skill, mental effort, judgment, and stress that's involved in providing a service. Then there's the practice expense RVU, which accounts for the overhead costs of maintaining a practice, including staff, equipment, and supplies, inpatient and outpatient. The malpractice RVU is the third component, and it covers the costs of professional liability insurance based on the relative risk of the service. So putting all three of those components together, the total RVU for a service is adjusted for geographic differences in practice costs and then multiplied by a conversion factor, which is a dollar amount set by the CMS to determine the final payment amount. And CMS reviews these annually and makes changes. So CMS is the major entity that influences changes in the RVU system over time because they're the final authority on how Medicare reimburses. Other private payers follow suit. So the other major entity that's involved in this process is the American Medical Association, the AMA. The AMA plays a central role in maintaining the current procedural terminology, the CPT codes, and the CPT codes are the basis for assigning the RVUs to specific services. The AMA also has the Relative Value Scale Update Committee, the RUC, and it was formed in 1991 by the AMA. It was formed in 1991 by the AMA, and the RUC is a multi-specialty physician panel that reviews data and makes annual recommendations to CMS on the RVUs assigned to each CPT code. So while CMS is not required to follow the RUC recommendations, historically it's done so 75 to 90% of the time. So it's a very powerful committee that we as physicians have influence on how we are reimbursed through this process. And then the AMA has that CPT editorial panel, which is a panel appointed largely by the AMA that is responsible for updating and maintaining the CPT codes. So changes in the CPT codes trigger reviews and potential updates to RVUs. So those are the major influences in RVU changes. Now, specialty societies, national medical specialty societies, provide input and recommendations to the RUC and to the CPT editorial panel. And those are the unique aspect that different specialties bring to the table in considering how to value a service. So it's important to understand that you want to be represented at that table as a physician in your specialty at both of those tables, the RUC committee and the CPT editorial panel. So let's take a moment and consider what specialties are currently represented on the CPT editorial panel. I'm just going to read off those specialties to you here based on the current membership. And this is as of May 10 of 2025. So family medicine, OBGYN, podiatric medicine, neurology, chiropractic, pathology, neurosurgery, psychiatry, oncology, anesthesia and pain medicine, internal medicine, ophthalmology, pathology, otolaryngology, pediatrics, radiology, orthopedic surgery, otolaryngology, gastroenterology, and interventional radiology are all represented on the CPT editorial panel. And as far as the members of the RUC committee, remember the RUC committee stands for the Relative Value Scale Update Committee. The current RUC committee members as of May 10th, 2025, specialties that are represented are radiology, anesthesiology, family medicine, pediatrics, pulmonary disease and critical care, neurology, general surgery, cardiology, orthopedic surgery, internal medicine, geriatrics and palliative care, hematology and oncology, obstetrics and gynecology, ophthalmology, audiology, dermatology, dermatopathology, sports medicine, physical medicine and rehab, cardiovascular disease and internal medicine geriatrics, internal medicine hospital medicine, critical care medicine, otolaryngology, pathology, emergency medicine, radiology again, neurosurgery, urology, general surgery again, gastroenterology, neurosurgery again, plastic surgery, family medicine again, and again, pulmonary disease and critical care. These are the current RUC members and the specialties they represent. And the whole idea is in your medical specialty, it behooves you to have a seat at the table so that someone is voicing protections for you so that your unique perspective on what you bring to the table as that medical specialist is represented and taken forward as the CMS, the Centers for Medicare and Medicaid Services, considers making changes each year. So how do you have an influence? How do you get your voice heard by people on these committees? Well, one thing is to join your medical specialty societies. I'm a member of many of my medical specialty societies, and that's one way. The second is to volunteer to serve. Committees for medical specialty societies always need people to serve, and once you're identified as somebody who volunteers to serve for an organization, it's easier to get your voice heard. Another way is to write a letter. It doesn't have to be snail mail. It can be an email correspondence that outlines why your perspective is important and to make sure that it gets into the hands of someone on the committee. Of course, that's going to be more effective if you somehow get that person's attention if you don't already have a personal relationship with them. So if you know somebody who knows them, who can give you an introduction, or who can put an introduction on your letter to them, then that may give you a little more of an audience with that person who's in the position of power. So that's something to consider when you're wanting to have your voice heard regarding these instruments that are used to dictate our reimbursement. So that is a primer on the relative value system, just a very simple discussion of what it is. If you'd like a more in-depth history of this whole system and how it's evolved over time, there are a couple of white papers that I found when doing the research for this episode that I will link in the show notes so that you can access those and read the history yourself. Remember, history is usually written to benefit the persons or person who is writing that history and what they represent. So just consider the source when you're looking at this historical perspective so that you can take that into account as you do your own research on what the relative value unit and the CPT code means to you as a medical practitioner in this day and age. I hope you've enjoyed this episode. The question is, what is your next step?
Your next step.
Your next step is to join us at the Doctors, Mentors, and Proteges Collective and get involved in our private community where we discuss personal and professional issues so that we all can help each other grow through the interesting opportunities that face us each as individuals and learn from each other's growth opportunities rather than having to experience all of these growth opportunities for ourselves. So if you'd like to do that, again, I'll have a link in the show notes so that you can join our free community and get your voice heard there and educate yourself there. Thank you for tuning in.
You're listening to The Doctor's Mentor, hosted by Dr. Lori Lee Barr. Podcast content is provided for informational purposes only and is not intended for the purposes of curing, diagnosing, preventing, or treating any disease or medical condition. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare, legal, or accounting professional. If you suspect you have a medical problem or you should have any healthcare questions, please promptly call or see your healthcare provider. Carefully read all labels and heed all directions and cautions that accompany products or services. Before using any strategies, activities, or products referenced in this podcast, consult with your lawyer, accountant, or medical professional. The Doctor's Mentor was created by Dr. Lori Lee Barr. It is owned by Peak Idea, LLC, Executive producer, Dr. Stephen Dent. Audio-video engineer, Richard Dent. The company, Dr. Lori Lee Barr, and the producers disclaim responsibility for any possible adverse effects from the use of information contained herein. This podcast does not make any representations or warranties about the qualifications or credibility of guests. Opinions of Dr. Lori Lee Barr are her own. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for statements made by guests. This podcast may contain paid endorsements or advertisements from products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services mentioned. Remember, one idea is all it takes to change your world.
There's more to explore at thedoctorsmentor.com.
Are you stopping at a hospital? Hello? Don't you know that hospitals are one of the sickest places on the planet? Don't touch anything in there and get out as fast as you can.